Okay, great. Thank you everyone for joining. My name is Venkat. I'm part of the team here at the Archives at NCBS, which is a public collecting center for the history of science in contemporary India. And if you haven't come to see our space in person, and if you're in Bangalore, please do consider visiting our space. We're in North Bangalore, and most of our collections are also accessible online on our website, which is archives.ncbs.res.in. You can just use any search browser to look for it, and you should be able to find the digital collections, many of which are actually around public health, which is also the focus of our conversation today. So as part of our programming at the archives, we also host a public lecture series, which we have been running since 2018, actually a year before the archive opened to the public. And I'm really delighted to invite all of you to this very special online conversation between Shreelata and Abhilasha, which is the 70th edition of the Archives Public Lecture Series. I won't take too much more of your time. I will just step in to just introduce Abhilasha briefly first. Abhilasha is currently coordinating a joint project implemented by the India Foundation for the Arts and the Archives at NCBS. She's an artist in residence as part of this project. She recently completed her PhD in history from IIT Guwahati, and her research areas look broadly at the history of infectious diseases and health in colonial Eastern India. And she's been an INLAC's research and travel grantee in 2022 and has also been publishing in academic journals prior to this. Abhilasha, thank you so much for agreeing to coordinate and steer this conversation on independent India's promise of people's health. Over to you. Thank you.
Thank you so much, Venkat. And thank you, all of you, for joining in from different parts of the country. It's an honor and privilege for me to welcome Professor Shreelata Rao Seshadri. She has taught me a decade ago when I was a master's student, and perhaps she was one of the key persons for instigating me into the field of health. And to be able to invite her for this talk, it really seems like we are coming a full circle. Thank you so much. Professor Seshadri has worked in the field of public health in various capacities for over 30 years now. She's currently professor and director at the Ramalinga Swamy Center on Equity and Social Determinants of Health with the Public Health Foundation of India. Prior to this, she was professor at Azim Premji University. She also led the setting up of the public health specialization for the postgraduate students. Her research interests varies from health programs, policy and systems, nutrition, environmental health, decentralization of health, and she has extensively published on all these fields in various journals and also on popular platforms, both in English and in Kannada. She is currently, she's also serving as a member of various institutional boards and committees. It's a real privilege for me to invite her today. How we'll go about this talk is Professor Seshadri would be speaking for about 25 to 30 minutes. Yes, ma'am?
I'll try and keep it down to 25 or 30 minutes. I've tried very hard.
Okay. And then I'll pose a few questions to her that have come up during my archival research, which I did at the NCBS archives. And then we'll open it up for the audience for their comments and to pose their questions. Over to you, ma'am.
Thank you, Abhilasha, for that very nice introduction, and also for giving me this opportunity to speak at this on this forum. I'm going to share my slides now. I have to say this was it was very nice to hear about your academic journey. We got talking over email without actually getting into the details of what you've been doing since we last met. And it's very impressive and very interesting. And we must catch up on that more extensively later. But thank you all for being here this afternoon. And today I will be talking about independent India's promise of people's health. And in this talk, I'm hoping to cover a few things. One is I will focus on the period just prior to and post independence for the most part, and travel through until the first national health policy, which was in 1983. But I do intend also to spend a little bit of time talking about what has come later. And the questions I want to think about, or want all of us to think about, is what was the state's vision at independence, and what was the kind of social contract that was set up between the state and the individual or the people in the country? How did public health and programming evolve over time, and why? And in this evolution of policy and program, what was the balance between collective and individual responsibility, collective and individual action? And how is that defined, and how did it play out? And finally, I want to leave you with a few questions on how can we frame people's health within the broader debates around social justice. So let's get started with a little bit of history, and I'm sure Abhilasha can correct me if I'm getting things wrong. But the health scenario in 1947 or pre-1947 was quite dire. There was very high mortality rates, very high birth rates. There were peaks in mortality due to famines and droughts, and also because of the pervasive poverty, endemic disease, and the desperate living conditions that people were experiencing. And there were famines, and those famines were often followed by epidemics. And those epidemics were therefore, the mortality was magnified because of the malnutrition and the general debility of the population. And from the 1830s on, the data show that there was a drought or a famine every 3 years. And it was then followed by an epidemic. And it could have been plague or influenza, malaria, smallpox, cholera. It was a long list of epidemic diseases. What were the services like at the time? Services were largely, they were meager, scarce. But those that were there were largely focused on British civilians and troops. The Indian Medical Service was set up in 1764, but it was meant for the troops of the East India Company. And then later it was expanded to be available for the British Army and for British civilians. Eventually, in the mid-19th century, it was expanded and extended to Indians as well, but it was a very thin sliver of Indians, those who were essentially serving the British in some civil capacity or the other. The sanitary movement that had taken hold in Britain by the early 19th century had its impact here as well. So a public health commission was set up in each presidency by 1885. And sanitary departments were also set up, and they were meant to look after public health functions, essentially to clean up sanitary conditions, to prevent epidemic diseases, to take care of vital registration, disease surveillance, vaccination, wherever a vaccine was available. And in 1886, something happened, which I think we are bearing the legacy of that even to this day, which is that the sanitary departments were bifurcated from the medical departments. So now, as you know, in most states, the public health department and the medical department used to be separate, but now have been united. But in those states where they are bifurcated, there is a different experience from those states where it hasn't. Then in 1931, the All India Institute of Public Health and Hygiene in Calcutta was set up, and they were tasked with doing basic research and to provide technical leadership. And prior to that, they had established a medical college also in Calcutta, which was meant to train native doctors to serve native people. And a combination of these interventions led to a reduction in mortality due to cholera and plague, for example, although other infectious diseases definitely persisted. So at that time, what were some of our leaders imagining a public health system to look like when we finally established ourselves as a new nation? So when you think of what Gandhiji was thinking, he essentially was emphasizing personal responsibility. And this included a well-regulated diet, exercise, and using basic remedies, using natural elements, etc. He was very skeptical of Western allopathic medicine and the institutions where it was practiced. And he really was very much in favor of more of a communitarian or a community-based approach to healthcare, where communities understood what their healthcare needs were and in a decentralized way address them with the resources that they had available. Nehru, on the other hand, had a very different vision, and he was in favor of state-led model for public health. And he also viewed health as a fundamental responsibility of the state to provide healthcare to its citizens. So it was not a private community-based idea he had in mind, but rather a large state-led institutional arrangement. And he was very much in favor of robust public healthcare infrastructure, particularly to combat the high levels of morbidity and mortality due to infectious disease amongst the rural poor. And therefore, in the initial 5-year plans, there was a great emphasis on disease control through central funding. So there were campaigns, plague drives, vaccination programs. And in order to achieve those goals, he also partnered with international agencies, including the WHO. In 1938, a national planning committee was set up, which also was tasked with thinking through various initiatives for that would be implemented come independence. And a very important aspect of this was public health. So the Indian leaders who were engaged in this planning exercise, they were extremely critical of the colonizers, and rightly so. And they took up the call for health as a right for all citizens. And as a result, assuring health as a right became an integral part of the discourse of nationalism. By the 1940s, it was common understanding. And the way of establishing the legitimacy of the independence movement and the post-colonial state. And two broad agendas emerged from there. The first was a sort of modernist agenda built on the idea of poverty as the root of all ill health and natural condition in India due to the drain of resources by the colonizers. So the idea was that this kind of poverty and undernutrition, that was the lot of the Indian race, needed to be addressed by technological solutions. And the best way to do that was to have a centralized institutional architecture, which would decide what were the health needs that needed to be addressed, and then go about systematically addressing those needs. There was another agenda as well alongside, which was more of a reformist agenda. And that agenda pointed to various regressive practices, superstitions, prejudices, cultural traditions. And they pointed particularly to early marriage as one of those sources of ill health. And their solution to this was to have an army of health workers whom they called sevaks, who would be possessed with a missionary zeal to go out into the community and sort of redress some of the harms that were caused by this kind of ignorance and superstition. Underlying both these agendas, however, was a real concern for the size of the population, not just the size, but also the quality of the population. And essentially that measures needed to be put in place to curb the quantity of the population and promote the quality. And that meant putting individual rights subservient to the greater good. So essentially, the contract that we entered into with the state at independence was to declare that health is a basic human right. It has to be delivered through centralized institutions, since people themselves did not have the capacity to bear this burden themselves due to poverty, ignorance, etc. And it was in this context that the Boer Committee was established. And in 1943, they published what was called the 3 Million Plan. And this laid out in great detail the three-tiered national health scheme. And essentially, those tiers were primary care, which was to be delivered at the community level. Then there was an intermediate level of care at the taluk level, which was a secondary unit which provided slightly higher level, more specialized services, and then the secondary level of care at the district level, which would, of course, be much more specialized and provide much more, much wider range of services. Now, the aspirations of this committee were, of course, excellent, but the capacity to implement these recommendations was very poor. In fact, the funding that was estimated at the time was, I read somewhere, was the entire GDP of India at the time, just for this, to implement this Boer Committee recommendations, which was clearly unrealistic. Over time, of course, some version of this was implemented. And over time, international funding has been sought for it. And along with that funding has come a whole bunch of other agendas as well, but we'll talk about that later. So now I think, we've come all the way up to independence and what the contract was with the state at that time. But then what happened? How did these policies and programs evolve in the next, I would say, 35 years until the first national health policy came into being in 1983? Because we have to remember, in the interim, the health sector developed largely through discussion, debate, through the priorities set in the 5-year plans and so on. And there were a series of committees that were constituted over a period of time where health needs, ways in which those could be addressed, the kind of institutional structure required, the funding required, all these things were discussed in those committees. But these were sort of ad hoc committees, and their discussions were kind of, intermittent. However, overall, what they recommended was that there was a need for a very strong primary care network. And that primary care network was envisaged at the community level. And in order to ensure that the communities were served and their needs were taken into account, and there was something of a people-centered health system coming into being, there was a shift towards having a cadre of community-level workers. It was also probably a pragmatic decision, because there was a huge paucity of human resources. So there were not enough trained doctors and nurses who could be deployed to all the health centers that were being set up over a period of time. So it seemed like a good solution to have these community level workers, who were called the auxiliary nurse midwives, ANMs. And partly also, of course, one of their major roles was maternal and child health and safe delivery and so on. So they needed to be midwives as well. So to have that cadre of workers, and that also kind of fit in with the reformist agenda of having these sevaks, working with missionary commitment. So that whole cadre came into being in the 1950s. They were meant to be voluntary workers, and the burden of providing primary care fell on their shoulders. And the other activities of the health system were focused on disease control, on managing and eradicating as many of these infectious diseases as was possible. So there were mass campaigns against cholera, malaria, TB, trachoma, leprosy, filaria, another long list. And there were some successes as well, because there was a point at which in the early 60s or so, when the campaign against malaria was so successful that there was even talk of having eradicated it. Of course, it came back with a great deal of ferocity later on. But just to say that some of these state-led campaigns actually worked for a period of time. Then, of course, there was a globally extremely important moment, which was the Alma Ata Declaration of 1978. And this was the declaration that set the Health for All agenda. And what it said was that the main goal of governments and the World Health Organization in the coming decades should be the attainment by all people of the world 2000, a level of health that would permit them to lead a socially and economically productive life. This was reaffirmed in 1998, since obviously the goal for 2000 was not met, and it had to be extended into the next century. Now, what was the background of this Alma Ata Declaration? Essentially, it was a recognition that there was a need for overall social development. And it's not only, and social development was a legitimate goal for health policy, and not only a focus on economic growth and making a fitter and more productive set of people who would contribute to the economy. There was continuing concern with poverty and also with population control that was not left behind. There were questions about the medical care model, and there was a lot of talk about examples of interventions that were community-based, that had encouraged and allowed for community participation, and how they had been able to create a change by bringing the community into the conversation. And there was definitely an interest in primary care, on expanding primary care and talking more about wellness rather than cure. And so because of this change in the discourse or the vocabulary that the Alma Ata Declaration brought in, there was an emphasis on issues that were not always central to the public health or the medical fraternity, which were things like safe drinking water, sanitation, things like public health measures such as immunization and so on and so forth. So, and prevention of disease rather than cure of disease. So these were things that were reaffirmed by the Alma Ata Declaration. And this is when the first national health policy of the Indian National Health Policy came into being in 1983. It was part of the commitment to the International Covenant on Economic, Social, and Cultural Rights, and also an outcome of the fact that India was also a signatory to the Alma Ata Declaration. It returned definitively to the primary care model, because as I had mentioned earlier, the focus had shifted towards disease control rather than staying with the primary care agenda that it had started out with. So as with the Alma Ata Declaration, it was critical of the curative oriented Western model of care and emphasized preventive, promotive, and rehabilitative primary care. It also recommended a decentralized, people-centered model of healthcare and brought back the centrality of the community health workers and their role in fostering and supporting community participation. And recommended also, there were other recommendations as well, for better surveillance of communicable diseases. Also, again, the preoccupation with population control, which revealed itself in the setting of demographic goals, etc. But the central idea was to go back to comprehensive primary health care, just as had been recommended by Alma-Ata. Now, all of these, changing scenarios over a period of 3 or more decades by this time indicated a kind of dynamic tension between whose responsibility is this? Is it the responsibility of the state? Is it the responsibility of the individual? And what does this mean for the person or for the objective or the idea of health as a human right? And this is, contestation that we are living with even today. It's not something that we have left behind. Something that happened then is happening even today. And there are certain drivers of this, shifting balance between collective and individual responsibility and collective and individual action. One of them is the changing disease profile. So with the growing burden of NCDs, the focus has shifted from broad collective responsibility and population-based health, public health approaches that were prevalent earlier. So there was a broad collective responsibility that the state owned to reduce the burden of communicable disease. So whether it was putting in the community health worker or running immunization programs or malaria spraying, there were a host of things that the state took responsibility for when the burden of disease was skewed towards communicable disease. But now with the shift towards non-communicable diseases, there's a lot more talk about individual responsibility. So this whole thing about lifestyle changes. So people are responsible for their own health. You watch your diet, exercise more, don't smoke, don't drink. All of these things are personal responsibility. And if, God forbid, you fall sick, then perhaps you had something to do with it. One example of personal responsibility in the case of an infectious disease was during the COVID pandemic and even earlier during the plague and so on, where people were made to feel responsible not only for their own health, but also for containing contagion more widely. So mask, isolate, keep your distance, etc. Wash your hands. It was considered to be a personal responsibility and personal action. The second driver is the changing health systems landscape. Linked with this shift in the disease profile, I would say it's a close link, has also been the shift from public provision to private services. So over a period of time, either under pressure from international multilateral agencies or through internal pressures, inability to commit funds to the public health sector and so on. Health as a right has now translated into health for those who can afford to pay. So as we know, this has really increased and exacerbated health inequalities tremendously. And there is plenty of evidence to show that where public health investment is high, private sector proliferation is low. And yet that lesson has not been, despite a lot of policy sort of noise around increasing investments to the health sector, that hasn't actually happened. And even in the public sector, there is now a lot of talk about paying user fees and this argument that people only value what they pay for. So even public services are no longer free. There is also a third driver, which is the shift from care to coverage. We started off with an imagination around primary health care, and that was grounded in the Health for All agenda. But now we have moved to universal health coverage. UHC, the C stands for coverage and not care. And the coverage also implies institutionalized service delivery rather than a more primary level, broad-based, people-centered health system. So what does this say about collective versus individual responsibility? On the one hand, universal health coverage is largely for conditions that require hospitalized care, which traditionally are supposed to be due to lifestyle issues, and individual responsibility is being called for to control those. And at the same time, there is, the community-based health system has more or less been neglected and abandoned. The last driver is the growing power inequalities between gender, caste, class, all of those axes of inequality. When you think about ANMs, for example, who are the lowest and least empowered rung of the health system, but they bear the greatest burden in translating priority agendas. The weight of whether it is disease control, maternal and child health, and now a host of other programs always end up on the shoulder of the ANM, who has the least sort of bargaining or negotiating capacity, and is the lowest, and whose voice is rarely heard. Let's put it that way. Although now more increasingly there is more collective bargaining going on in various parts of the country, but it's still not as much as perhaps it should be. The urban and rural divide. Rural health systems are chronically overstretched, under-resourced, and urban health systems are facing a different kind of problem because they're so skewed towards expensive private health options. Both of these call for very different kinds of responses from the state, and it muddies the waters of who's responsible, who should act, who should pay, who should provide services. It's a very complicated situation, and one that the health system is constantly grappling with. And of course, the inequalities between different communities. For example, tribal communities who are persistent, there's persistent undernutrition, there's disproportionate morbidity. So even here, what are we talking about when we are thinking about collective versus individual responsibility? So finally, it's not a linear journey. I think we've gone back and forth on all of the issues. On who pays, who's responsible, who provides services, etc. But essentially, public health policy has been about navigating power structures, whether at the national level or at the policy level. And these power relations and political narratives have been critical in shaping public health policies. And this includes considerations around who sets the agenda, and then who pays the price for it, right? And I think the elites who are in charge of setting the agendas for the most part, they imagine that they're doing it for the greater good, but it may be causing tremendous private hardship. We saw this, I think, most starkly, most recently during the COVID pandemic, when all the lockdowns and the draconian measures were meant to actually contain the pandemic, but neither did they do that, nor did they provide any safety net or safeguard people's best interests or the public good. People suffered tremendous economic, social, psychological, and physical hardships as a result of that. But it was all meant in the collective common good. So in this context, one can ask, what then is the contract between state and society? We started out with what seemed like a very clear contract, but now there is a need to renegotiate this contract because of all the fissures that have appeared, whether it is in terms of the growing inequality, whether it is in terms of the changing burden of disease, which is presenting new kinds of challenges. And how does that social contract get rewritten in the evolving context? And I think this is where civil society organizations can play a very critical role. People's action has a great deal of importance and can really sort of provide evidence and speak truths to power and ensure that health policy gets rewritten in a way that is inclusive, that allows for broader citizen participation, and is more in line with the principles of social justice. I'll stop here, Abhilasha. I hope I didn't overshoot my time too much, and I'm happy to take questions.
Not at all, Professor. You're bang on time. Thank you so much for the insightful talk. And it actually helped me to go back, revise a little bit of the archives that had accessed online on the website of the archives of the NCBS. Wonderful talk. Thank you so much. It's one thing that you pointed out, and it stuck to me, was the role of the health workers. And in the archives of one of the health magazines that I'm focusing on, which is called the Swasthind, um, pages after pages. So the Swasthind was an official health bulletin which was published by the government of India between 1957 to 1998. And pages after pages, I see pictures of health workers interacting with people. And one of those pictures is what we have used in the poster. And it really shows the kind of presence of the state during the 1950s, 60s, 70s, and it slowly starts decreasing a little bit in the 1990s. And this is something, this kind of picture of people interacting with the health workers is something that we forget oftentimes when we read about private participation in the health sector today. And thank you for bringing that out. This one question that comes up, and I would like your comments on that, is that since the 1950s, community participation in health has always meant focus on women, on mothers, whether it's nutrition or it's child immunization. What, in your opinion, has been its impact on health outcomes?
Well, this packaging of women and child it goes back to the traditional roles that are envisaged of a mother who is supposed to be within the family, the person who provides care and, is responsible for the upbringing of the children and so on and so forth. And I think the reinforcement of that role through the ways in which the state also designs their interventions. So the fact that there is a whole women and child department, and they are responsible for nutrition, and the Anganwadis and so on are run by the Women and Child Department in most states. And even when you see all the visuals, it is the women, and then the community health worker, they are an army of women, whether it is the ANMs or the Ashas or the Anganwadi workers, all of them are women. And the idea that women should bear the majority, or bear the responsibility for all this care work. In the case of the community health workers, they are paid nominally, certainly not valued as much as they should be, given that they actually bear the brunt of implementing all these priority health programs. And within the household, it is the woman's care work which is unpaid, and she is meant to provide those care services not only without any pay, but without any recognition either. So when you say what is the impact, I mean, what has been the impact of this? I think the impact has been to, again, reinforce the idea that these are women's roles, and these, and they're supposed to be done because women are caregivers. That's what they are, And there is some scholarship coming up more recently, I mean, not only now, but in the last few years, looking at the role of men in child rearing, in making certain decisions around health for the whole household and so on. And in every one of those instances, they have found that it actually improves, or you have a better outcome when these things are done by both partners together, and these kinds of caregiving is done as a joint effort rather than being left to the woman alone. And the kind of pressure and the both the burden physically, and also in terms of her own mental health in having to shoulder this responsibility alone, has been tremendous. And I think the reinforcement of this role is something that we really need to question and start kind of reimagining and redefining that.
Yes, definitely. I think I'll pose one more question before we open it up for the audience for their questions. Um, you have been a resident of Bengaluru for many, many years now. So, as a resident and a researcher of the city, what is your thought on how an urban center like Bangalore measures up to concepts like health equity or community participation vis-a-vis the rural neighborhoods of Bangalore?
I would rather than confining myself to Bangalore, I think it would be useful for us to think about the architecture of urban health, because for the longest time, since independence, in fact, and even when you come right down to until the National Rural Health Mission, which was much more recent. It was after, when was it, 2019, was it 95? Somewhere around then. When you think about it, the focus has been on providing healthcare to rural populations. And even this the three-tier health scheme that had been outlined by the Bore Committee was actually implemented in rural areas first and has become quite entrenched there. So you have the primary health center, then you have the taluk hospital or the CHC, and then you have the district hospital, etc. And it's all, it may fall short of the population requirements that have been laid down, but at some level it is kind of consonant with the way that it had been envisaged. But when you look at urban health systems, it is really a little bit of a hodgepodge. We did that urban health study and Bangalore was one of the cities. We had two other cities as well that we looked at. There are, apart from the fact that there is a huge shortage of the number of health facilities in the public sector, there is also a large governance issue, because some of those health centers fall under the state health system, some of them fall under the municipal health system. There is no coordination or sort of planning that takes place between them. There is a huge proliferation of the private sector, much more than in rural areas. And people, trying to access health services in the private sector, it's much more expensive, but it is much easier because it's much more accessible. It is around every corner, whether it is a pharmacy or a small clinic or a regular hospital, depending on what people can afford. They can go to a whole range of private providers and they are readily available. And especially in the absence of a robust public health infrastructure, there is really not much of a choice. So if I think it's, people are talking about now, what is it? It's not reshaping the health system, but trying to figure out how to use all the resources, public and private, in a way that can still ensure health equity. Because right now it's highly inequitable system that has evolved due to loose regulation and loose kind of oversight of how the development is occurring. But is it possible to in some way create safety net programs whereby even in this kind of a landscape, you can have more equitable systems, especially for those who are, the most vulnerable and marginalized and least able to pay for health services. And in urban areas, there are a lot of people on the move, as we know. There are migrants. There are plenty of migrant people who are itinerant. They come and they go. How do you provide for them? These are challenges that I think urban health systems have to start grappling with and start addressing.
Yes, thank you. We have a couple of questions online, and everyone, please feel free to pose your questions. You can unmute yourself, introduce yourself, and ask your questions aloud, or you can type in your questions in the chat box. We have one question from Gayatri Sabarwal, and she asks, in recent times, the only public health issue that caused the public to come out and protest was the stray dogs issue, and it had an anti-public health outcome. Are there any significant examples where civil society has recently been able to affect positive changes?
I mean, that's a broad question. Yes, of course, there are many areas in which civil society can and has made a difference. If you ask recently, I would be a little bit at a loss, but I think even this if you look at the way that people have been, there's been more and more of a discourse around how health equity can be more effectively addressed. And people are talking about emerging health issues. For example, there's been some interest in trying to understand how heat and climate change are affecting the health outcomes of people. And there are groups in Bangalore, for example, like Hasiru Dada and others, that have been working on this issue and trying to raise this as a public health issue that needs to have some kind of policy and programmatic intervention. So I think there are ways in which there are instances when community mobilization or civil society action has made a huge difference. And tobacco control is another great example, actually, of civil society action to increase tobacco taxes and to put in place laws that prohibit the sale of tobacco products close to schools and hospitals and so on, and single sticks being sold and so on. So there are some good examples where it has worked. And then, of course, there are examples where there's been, strange outcomes like what you just pointed out.
Thank you.
There's one more question by Renuka Kulkarni. She asks, people only value what they pay for. Will a system of free healthcare work in India, ensuring quality and equity without causing economic hardship happen? Yeah.
Economic hardship to whom? Just a clarificatory question of my own. I'm not sure. Yeah, well, anyway, broadly, I will say that there was a time when there were truly free services being offered in public health systems. It worked, and people were accessing those systems because there was sufficient investment in public health care. Even today, you go to places like Tamil Nadu or Kerala, for example, where public health has much greater political salience, where people are much more aware and demand more out of the health system, where it is still the case that you can get free health care and you can get good quality care for the most part. So it is possible, and what it needs is a lot of political will, and it needs the government to live up to its promise, even if it lives up to the promise of between 2.5 and 3% of GDP invested in public systems, and it regulates the private sector adequately so that they live up to their commitment that they will provide free services for up to 30% of the people whom they treat in their facilities. It is still possible, but it's not happening because there's not enough, there's not enough interest in ensuring this.
Thank you, Professor. I'm sorry if my question was not properly phrased. I think the last bit just, fell off. But yeah, thank you. I understood what you're trying to say.
Okay, no worries.
Okay. We have another question from Shivani. If any one of you could want to unmute yourself and ask questions, please do that. It'll be really good to look at one of your faces and then. Okay, but I'll read out Shivani's question. With India's total fertility rate now below the replacement level of 2.1, does population still pose a significant challenge to the country's healthcare system?
Well, the total fertility rate coming down, there's two issues here. One is the issue of equity. And that is that along with the fertility rate coming down, it's not as if those people who are in need of public health services is reducing. So there is still a huge level of income inequality, health inequality. And therefore, there is going to be an ongoing need for public health systems to be strong and to be well-funded, well-resourced, and to be able to provide high-quality services. That is one. But the other thing, which most of us realize and demographers know, there is a thing called population momentum. So even if the TFR comes down today, it will take 30 or 40 years before the population actually starts to decrease. So I don't think, certainly not going to happen in my lifetime, but when that happens, I hope that the public health system will be ready for it.
Thank you, Professor.
Abhilasha, can I go next? I have typed my question, but I'd like to ask ma'am as well, if that's
Please
fine.
go ahead. Yes.
Yeah. Professor, I've been sort of concerned about the general trend towards privatization of healthcare and how we're seeing a huge gravitation of also a lot of our PMJY/state insurance programs going towards private sector. And as someone who's worked on the interface of both these sectors, I find both of them downplaying the other, the private about the public and the public about the private. And I'm at odds, just professionally and just in terms of the discourse of where does the balance in this lie? So we just wanted to hear your thoughts on that.
Well, I don't know about a balance, I don't know what kind of balance we're looking for, because what we need is a strong public sector where, for the most part, people's health needs are taken care of. There are countries that do this. I mean, the UK has the National Health Service, and so does Canada and several other countries as well. And it's not that we cannot invest in a similar such service or a similar program where people rely, for the most part, for most of their health needs on public services. And then maybe there are certain specialized services which can be provided in the private sector, and those can be subsidized for those who need it, or there can be a strong insurance program that reduces the cost of care and so on. But I don't think there's any alternative for a strong any alternative to a strong public health system. So when we're talking about balance, I don't know where that balance actually comes out. It needs to be skewed. It's not a question of balancing the two of them. We need to prioritize and we need to invest in public health systems. And that's really the only way that we can ensure better health equity than what we are seeing today. And if we invest in expanding the system, properly resourcing it in terms of human resources and drugs and all of the other things that are required, training, capacity building, all that's required to actually have a high quality public system. If we were to do that, then we won't be talking about balance at all. People would, 2 generations ago, maybe not one, but 2 generations ago, everyone went to the public health system. And because number one, it was perhaps the only system really around, but also it was good and it provided the services that people needed at a quality that they found acceptable. But that has, that has now fallen by the wayside, and all of the resources are being diverted to private care, including, as you pointed out, the PMJRY, which could have been a tool for strengthening the public health system, actually. If it were deployed properly, we could actually have strengthened the health system and done it in a really innovative way, in which, but we missed that bus.
Thank you, Sapna, for asking the question. We have, I hope we have some time. Probably we'll take.
Yes. Sure, go
Okay.
ahead.
Yeah, we'll take 2-3 more questions.
Okay.
Is there anybody who? Okay. Yeah, we have Tanisha who is asking, are there any other models of public healthcare that can help us think about what healthcare could look like in India?
Well, yeah, there are, of course. There are some very interesting models of different initiatives, which we can sort of maybe emulate parts of them, even if we don't take the entire system. There are very interesting experiments. It's no longer an experiment, actually, a long-standing program in Latin America, for example, where they have a system of conditional cash transfers to families for for ensuring certain basic health, nutrition, and education inputs for their families. And it's had an amazing impact on reducing malnutrition amongst children, increasing school enrollment and retention, and improving health outcomes for the entire family. It's called the Bolsa Familia, and it has other names in other Latin American countries. We have a very limited version of that, which is the JSY, but that's very focused on just institutional delivery and nothing else. It could be expanded and made much more, much more broad-based. And I'm sure it would have excellent impact as well. There are, old established systems, like I just mentioned, of, let's say, the National Health Service, where it has its own problems, definitely. It's not like any of these systems is perfect, but it does ensure a basic level of, reliable quality health services, which if we were to design, we already have the skeleton of a health system after all. And in many places, it's working reasonably well. Well, why don't we try and incorporate some of those elements into our existing health system to strengthen it and make it closer to what we are looking at in some of these other health systems. It is possible, and in pockets things are going very well. I mean, there are very interesting and interventions that are working very well, whether it is palliative care models in Goa or Maharashtra or Kerala, or other kinds of health system interventions that are working in pockets. If we can think of ways of expanding those, I think those would be that would be very useful.
We have Ankur who's asking a question. When we talk about universal coverage, we get to see NCD's mental health get attention and some action from government. Yet, oral health remains a neglected segment and highly privatized segment of health. How can we as researchers bring attention to this?
Well, I'm not sure. I suppose the oral health, though, you're right. It is a highly privatized segment, although, there are big dental colleges and so on around. But one of the issues that the government is very concerned with is oral cancer, and its its association with tobacco chewing and so on and so forth. And there's been a lot of advocacy around reducing risk of oral cancer by addressing the tobacco lobby and things like that. So perhaps the way to go about it is to identify some of the risk factors for oral problems, and focus in on one or two conditions that are extremely first of all have a very wide prevalence, but are also extremely dangerous, or the risk is very high to the person's health, and maybe even causes high mortality. So to identify a few issues like that, and then build the evidence around it, and have a sustained advocacy campaign, I think that has proven to be something that's quite effective. So, and that's the best advice I can give you. I don't know much about oral health, I'm sorry.
Are there any other questions that anyone would like to pose? Okay. I think we have run out of questions now.
Okay.
Yes.
Shreelata, I was wondering, just a procedural thing, would it be okay for you to share contact information in case people want to reach out to you via email and such later? Just something you're willing to share, that would be great in the chat. In
Yeah,
case people
sure.
would like to. Yeah.
I've just put my email in there. So
Great. Thank you.
yeah.
Ritvika has hand up. Abhilasha.
Yeah. Ritika, please go ahead. You have your hand up.
Yeah, hi Abhilasha and hi Professor. Thank you to both of you for this wonderful discussion and your presentation. My question is to both of you, to Abhilasha also, but first to you, ma'am. Post the COVID crisis that India saw, what has been your kind of observations around the shifts in public health policy, if any? And I kind of refer to, there was a document, I think, published by Niti Aayog in 2020, which was like a vision document with 2035 on public health policy. And I was very curious how they had used the word, I think, surveillance, health surveillance, vis-a-vis care and public health policy that we have been discussing so far. So yeah, your thoughts on that, and also probably to Abhilasha is, since you have been studying Swasth Hind at the archives, and there have been kind of major, I think, tipping points around epidemics in the past. And do you have any observation that you have found at that point of time, like that the government or the health policies have kind of addressed towards epidemic in terms of prevention, care, and post recovery and restitution of that? So yeah, thank you.
Why don't you go ahead, Abhilasha, because I'm going to have to ask Ritvika to repeat a little bit of her question. So you go ahead and I'll come back later.
Yeah. So in the health bulletins, you're right, we do see tipping points. We see that there are certain years when there is a lot more discussion about the particular disease. For instance, smallpox becomes a big concern in the 1980s, but it was also a huge concern during the 1960s. And there are a lot of pictures in the health bulletin of how the state is completely in control of the epidemics. And there are pictures and articles on how health workers are administrating vaccines and vaccination drives are going on. So yeah, a strong, as I said earlier, a very strong presence of what the state is. But the picture is not a lot, not definitely, we don't get a picture of a lot of coercion or force, the way we come across during the COVID pandemic, which is where we really experienced it. But in the written archives of the 1960s or of the 80s, it is more of, a kind of a collective participation in the vaccination drive, and a lot of government trying to educate people, a very, very collaborative kind of a scenario that we see in the written articles and the pictures. But what people experience is probably very different, and this is what we could see during the COVID-19 pandemic. And I would like to pass on the question to Professor.
Yeah, I would like if Ritvika could just repeat the early part of her question, because I think I kind of missed a couple of words. I didn't hear her quite as clearly as I
Yeah.
would have liked.
Sure. My question to you, it's stemming from, that India was one of the, like, I mean, the COVID crisis we all know, and the after effects of it, and how also it was dealt in terms of getting access to health, getting access also to vaccines, boosters, which continued after the COVID pandemic, kind of the long run of it. In that context, do you think, or I mean, there has been shifts, of course, but in terms of the state's intent or towards public health policies, what has been the major markers of shifts in that post-pandemic for a country like India? And my other question was around, I think, year 2020, there was this kind of vision document prepared by the state, by Niti Aayog, for a 2035 for a public health policy, and where there's a certain kind of wording of it which I kind of always catches my attention, which is, like, I think, public health surveillance. So in terms of surveillance by the state and vis-a-vis care provided by the state, what has been your observations, or what do you think has been like major shifts post pandemic for a country like India in terms of its public health policies?
Yeah, so just to address your concerns around the surveillance issue, I think a lot of people have been concerned about it as well, because while it sounds like good public health, because surveillance is one of the sort of keystones of public health systems in order to track diseases, what is the prevalence, what is the, morbidity, mortality, et cetera, incidence of new disease conditions. All these are sort of the basic building blocks of public health. However, the plan of this public health surveillance system of using individualized data and kind of making it, traceable back to the individual through the UHID and so on and so forth. There is always a worry, especially, and I think it goes back, I think, to broader issues of trust. And the issue of trust within the health system has been one that has occupied many people for various reasons, because how do you ensure at the patient level confidentiality and privacy and so on? Those are not things that are valued within the public health system. And you can tell that even when you go for a consultation, there's no concern at all for privacy confidentiality. And other than that, people don't trust the quality of care. They don't trust that the medicines that they're getting are not going to harm them. There's a huge trust deficit. And in the context of that, if you're going to have a surveillance system that's going to be that on the face of it seems very all-encompassing and perhaps even intrusive, then I think there needs to be a lot of work behind the scenes that has to happen first before people are going to be accepting of this kind of surveillance. Disease surveillance for public health purposes will suffer if there isn't that those exercises to build trust don't precede the implementation of that kind of a measure. That's what I feel. And in terms of what have been the major developments in since COVID, I feel there's been a lot of push more recently on technology, using technology for health interventions, whether it is telemedicine or AI-driven, interventions, and providing distance care in various different ways, and so on. And it all argues for a level of technological capacity that I don't think the system has at the moment, and also is perhaps not really appropriate for our, the kind of the socio-economic, socio-cultural context in which people access and seek out care. So it seems to me that is a growing area of priority, and perhaps one that needs more conversation and discussion.
Thank you so much.
I think we may have actually, unfortunately, run out of time, but I do hope this is a start to the conversation. Abhilasha, was it something that you'd be able to take forward? I mean, is there something else you'd like to wrap up with?
No, just a big thank you to to everyone present here for their really insightful questions and comments from Professor, of course.
Thank you very much, Venkat, Abhilasha, and the NCBS team for having me. It's been a very enjoyable experience. Thank you so much.
Thanks, Shreelata. Thanks again, and thanks everyone for joining us today. We should have a copy of the recording available on our website through the Archives Public Lecture Series site in a couple of weeks, or in a week's time. So, yeah. I'll stick around till the end of this, but thanks everyone. Have a good day.
Bye.
Thank you. Thank you so much, ma'am.
Thank you.
Abhilasha, thanks again.
Yeah, thanks, Venkat, and thanks, Ritrika, Datri.